There's going to be a lot of moving moments of today. So those of you who joined us last night for the Nocturnist will know the emotion involved in the work that we do. We do it with passion. The rest of the program is about looking forward. And that was done intentionally. The other thing that was intentional was we brought international partners, and I deeply thank all of them for the long journeys they took to be here from around the world. So we will start this discussion and dialogue about the future of global health by welcoming our keynote speaker, Ambassador John Nkengasong. Ambassador John Nkengasong is the Executive Director for Higher Education Collaboratives and Strategic Initiatives at the MasterCard Foundation. Prior to being joining the MasterCard Foundation, he served as the U.S. Global AIDS Coordinator and Senior Bureau Official for Global Health Security and Diplomacy at the U.S. Department of State under President Biden, where he established the Bureau for Global Health Security and Diplomacy, which is functional today and involved in PEPFAR, TB, malaria funding initiatives. He previously served as the founding director of the Africa Centers for Disease Control and Prevention, Africa CDC, and led the U.S. President's Emergency Plan for AIDS Relief, PEPFAR, as ambassador at large. He has acted as senior bureau official for that office. Some of you may also be aware that Ambassador Nkengasong has some roots in the Bay Area and spent some time as a Fogarty trainee with Art Reingold at UC Berkeley. So we welcome Ambassador Nkengasong back and look forward to your remarks about the future. Ambassador?
Good morning all. Please, it's raining. We want to hear, I bring warm regards to all of you. And it's raining out, but I really want this celebration to be a very warm celebration. Congratulations to the Institute for the 25th anniversary. What a milestone. And I just learned something that probably, and perhaps if I heard rightly, that this institute was perhaps the first Global Health Institute in the nation. So congratulations for that. Let me then thank the leadership for giving me the honor to be the keynote speaker, which I'm getting nervous to be a keynote speaker at a 25th anniversary. But I will calm down and hope that I can walk you through my reflections on where we go from here in global health. The Chancellor, if you're still here, thank you so much for your warm welcome. Dr. DeBaz, thank you for being a pioneer. I have, as you heard, been privileged to be a pioneer in setting up institutions, including the Africa CDC, and I know it's a very, very challenging job, including setting up a new bureau at the State Department. So congratulations for the work you did. Let me then say that it's truly an honor to be standing in front of someone I consider as a colleague, a friend, a brother, but a mentor, Ambassador Goosby, who I have drawn a lot of inspiration over the years. I heard just from him a few minutes ago that he was planning to retire, and I was thinking about retire and do what? I mean, he's been a true mentor for everybody. I was privileged to be, as you heard from Dr. Nahib, the 5th ambassador or the coordinator of the U.S. Global AIDS Program, and Ambassador Goosby was the 3rd coordinator. And I was sitting next to him and joking that if this was the Catholic Church and you are the Pope, you'd kind of find which Pope you carried a new name, and that name was, for me, was going to be Goosby, because I was tremendously inspired when he led PEPFAR, and I was a branch chief at the CDC. Okay, and I would never have imagined that I would walk into very big shoes like those that Ambassador Eric Goosby created. He managed, I learned watching him from far what dignity means, respect, humility, but foresight and determination in setting goals. I mean, and I'll forever be thankful for the mentorship, Eric. Thank you. So I thought that I'll get to the future of where we go from here. And I'll meet up front in an act of humility and respect that I don't know what the future of Global Health looks like. I think it is at a crossroads. I hope that at the end of this discussion here, as a pioneer institution, we will be able to collectively chart that future. But I'll share my thoughts. But in order to do that, it's best to take you back and let's walk the journey of Global Health. What is it? It's Global Health. What have we achieved? And then so that we can help us chart the future going forward. So just bear with me. The first few slides will mainly be focused on the evolution of Global Health, excuse me, which is a fairly recent concept, and the inequities that Global Health seeks to address. Secondly, I'll look at the progress and challenges very quickly, and then that will set the stage for what I really want to talk about, which is the Global Health at the crossroads and the need for a new Global Health order. Should have put a question sign there so that it is not what I'm asking for. I'm asking the question if we should be thinking of a new Global Health order. So those are three things that in my time allotted I would like to do. So bear with me. I think when you all heard Bill Gates, who is a hero in Global Health, talked about the definitions, it is real. What is Global Health? A few years ago, I believe it was in 2009, Jeff Copeland, former director of CDC and a series of highly respected Global Health leaders, came together and wrote a viewpoint in The Lancet where they were struggling with the concept of what is the definition of Global Health. In that, of course, it's a long paper, but the top line of that was the definitions greatly vary and is often little more than a rephrasing of a common definition of public health or a politically correct updating of international health, end of quote. So I've struggled personally after 30 years. I just retired from the US CDC after 30 years, and on the 14th of March, when I handed over my badge as the Deputy Director of Global Health at CDC, I started reflecting, what is it that is Global Health? So I stayed away from the definition. I said, well, it's so difficult for me to define. Let me focus on the purpose of Global Health, which is a lot easier. I think there are two things that the Global Health should seek to do. It should seek to address, improve the health and achieve equity of all people worldwide, of all people worldwide. We use the word global health very frequently, but we should also think of health is global. So just reversing those two words. It should also think about transcending country boundaries, transcending country boundaries. I'll say this now, and I'll say that again, that no one individual can live alone. No one nation can live alone. Anyone who thinks they can live alone is sleeping in a revolution. I think that applies to our nation, and I would like that to be the central theme of this conversation. So I'll focus not on the definitions, but on the purpose. So equity is key to global health, achieving that, which I highlighted in the purpose. The purpose of global health is not about equality. It's about equity, such that the person with the little guy with a yellow shirt, a yellow pants, should be able to have access and see over the fence. I've dignified that little guy by calling him Dan, just so that as we walk through this journey, we should keep Dan in mind, that it's not about making sure that everybody has everything equally, but that you give Dan the right tools so that he can look over and see that. And even better is justice, such that we truly bring down that barrier and we can also have access, okay? And that is justice. And if global health doesn't address that, there are serious consequences, and I'll argue with evidence that those circumstances have prevailed in front of our eyes. It's amazing that when we talk about global health, we should look at the architecture of global health, excuse me, the architecture of global health, but also talk about the concepts of global health. Amazing that when I was preparing this talk, I thought of where did we start with the concept of multilateralism? It started here in San Francisco, right here. So it's interesting that 25 years of global health in San Francisco, we are celebrating where the UN Charter was drafted, debated, and agreed on here in San Francisco. And that was the founding of the United Nations. The United Nations became the underpinning of multilateralism. And it has shown, as I was indicated at the bottom part of this slide, the power and the limits of optimism of multilateralism. We are struggling with where we go with global health because multilateralism have shown its benefits, but now it's showing its limitation. And fast forward, WHO was created in 1948, and you see across the board what the power of multilateralism has done in eradicating diseases and expanding healthcare across the world. So the concept of global health, that was the structure that brought us to where we are today. The concept of global health is not new. It has evolved, as Jeff Copeland said in that Lancet paper, over the years. First of all, it was called tropical medicine or colonial medicine. And this was in the early, the 19th century and early 20th century. Whose purpose at that time was to preserve the health of European colonial rulers and to protect health consequences related to tropical diseases. And I'll come back to that shortly. Then it evolved to international health and then to global health, which became popularized around 2000. So each period and each phase has its context. It is not a bad idea, or it wasn't necessarily a bad idea what tropical medicine did. It was the context of what global health was dealing with at that time. I say that because when we have a discussion today and chart the way forward, it should be put in the context of where we are today. When the WHO was created, the world was about 2.5 billion, and today we are about 8 billion people in the world. So let me just ask that you read this. This is a famous pathologist from the UK, British pathologist, and he says, I invite you to read that. We can then trace how improvements have been brought about, usually first with a view of safeguarding the health of the officials and European traders, and later undertaking also the treatment of natives, by which two purposes would be simultaneously accomplished. That is, a benefit to the health and well-being of the native and further protecting the white man from native-borne infections. That was then, at that time. So global health is a complex interplay. I say this because as we chart forward, we should be looking at those structural elements that drive inequity in global health. And this is a cartoon that I borrowed from Madhu, Pierre, whom I mean all of you or some of you know. And it traces those interplays and complexities as an elephant, the parable of an elephant. Regardless of where you touch, you think that is the elephant. And it ranges from lack of diversity and equity and inclusion to governance and leadership, racism, all kinds of concepts, colonialism and supremacy there. These are all concepts that shape inequity in global health, and we cannot ignore that as we chart the future for global health. In 1971, a paper was published in The Lancet by Julian Hart, a famous paper, and he said simply, the title was The Inverse Care Law. And he stated that the availability of good medical care and other services tends to vary inversely with the need in the population served. The purpose of a new global health order should seek to deconstruct the law. It should seek to deconstruct the law. If we do not deconstruct the law, 50 years down the road, this slide will still be valid. So global health equity is important for several reasons, 4 reasons. First of all, is human rights. Second is a global health security for all of us, and I will justify this shortly with a COVID example. It has economic development issues and also social justice. Social justice. Look at what social justice can do when you have inequities in global health. Antiretroviral therapies were available in the United States and Europe in 1996. And it would take 10 years before they were available in Africa. And between 1996 and 2006 timeline, about 12 million Africans died, I will add needlessly, of HIV. 12 million. That's what inequity and injustice does in global health. Then we thought we have seen it all. COVID hit and the issue of vaccines. And I'll ask that if we truly are going to chart the future of global health, you just cannot be a scientist. You also have to be an activist all the time. When COVID hit, I was heading the Africa CDC, and it immediately occurred to me that vaccines would be available, and the slide I just showed you, the inequities that characterize the slide I showed you for HIV/AIDS will come into play. So we started making the right noises. We published a paper in Nature where we said, history must not repeat itself. Global and continental cooperation are essential because of the lessons that we learned from HIV. So the vaccines became available. And COVAX was created, which was an international mechanism to access vaccines, and it still didn't address the inequity issues there. Just read those titles from Time magazine and others there. It says COVAX was a great idea, but it's now 500 million short of doses. It's what went wrong, and then a broken promise, and the inequities that characterize the distribution there. Because of that, because of inequities, and because of the moment, it forces leaders, political leadership, to take place. People have always argued or discussed about what happened with COVID in Africa, or the untold story of COVID in Africa. We just published a book with a series of friends who we worked together to fight COVID. But the political leadership of the continent was so important. I say this because, again, as we chart the future of global health, we should think of political leadership. It's so important. Every 2 weeks, under the leadership of President Ramaphosa, he used to pull all of us together and he said, Dr. Nkengasong, as the director of Africa CDC, tell us where we are with this pandemic, what we have to do, and what you need to do your work. So we'll come on a Zoom call, and the topic on discussion here was vaccines, access to vaccines, because of inequities that we saw. You can see there President Tshisekedi, President of Ghana, President of, President Kagame is there, Macky Sall is there. At the end of this meeting, I said to them, you have to address this issue. Let's go to Germany and meet with the BioNTech group and figure out how we can work together to bring vaccines to the continent. And there we went. The picture on the top there shows those leaders. I mean, Tedros is next to President Kagame, President Macky Sall, Nana Akufo-Addo is standing next to me. That is 2021. And fast forward, what happened? Down here is in 2024, December, the same presidents are inaugurating a vaccine, mRNA manufacturing in Rwanda. That is what inequity does. It forces the leaders, the political leadership. But you and I, as scientists, public health experts alone cannot do it. You need that political umbrella. So this is an inauguration. And today in Rwanda, mRNA vaccine production is taking place. In Senegal, there is a groundbreaking of the vaccine production in Senegal by President Macky Sall. On the top right-hand side is we move from that conception to the facility and the inauguration of the facility and the MasterCard Foundation support for that to happen there. Again, as we construct public health and think of public health for the future, you have to know when to take your hat off as a scientist, be that architect, wear that construction gear, and go to meet with the president and say, we have to do this, and you are there marching and showing that it can be done. Production of medical oxygen is now happening on the continent in a coordinated way, which was a huge problem when COVID hit because of the inequities that have driven the demand across the continent. So let me now move to progress and challenges there. And needless to say, Dr. Nahib mentioned the progress that we've achieved in Global Health. We can spend a whole week, a whole seminar discussing the progress in Global Health. I will not touch on that. But suffice to say that a paper was published in The Lancet just a few months ago, and it really shows the power of vaccination. If you imagine the life expectancy that we've all enjoyed across the world, differently, of course, vaccines have played a critical role. And the slide you see here shows death averted from vaccines. This is since 1974, and the deaths averted, especially in children. The powerful impact of vaccines. So when I hear today a debate on vaccines, I think it's a false debate. We should all rally around and not sleep during a revolution. We should let our voices be known. Vaccines have brought us far, and we are where we are today because of vaccines. HIV has declined in a rate that we couldn't believe. In 2000, when this institute was formed, HIV was almost killing a whole continent. When I met with the president of Botswana, and I'll show you a picture of that, he said, Ambassador, when you all came to help our country was going to be extinct. But today, we are where we are because of political commitment. Life expectancy in those countries, you can see in Botswana, South Africa, Uganda, Zimbabwe, had decreased significantly. And the GDPs had decreased about 2.6 percentage points. We've all collectively, in the power of multilateralism and Global Health, eradicated one important disease, smallpox. And these are two books that I urge young people in public health or global health to read. One by D.J. Anderson and the second by Bill Fege, who was the former director of the US CDC. Having said that, again, as I said, the intent was not to review all the successes in global health, which has brought us today, but it's just to highlight the successes. We are challenged in a way that we've never been before. The population is rising. The curve or the diagram you see on your far side there shows population growth. Just look at where Africa will be 25 years from now. 1 in 4 people in the world will be an African. That is what that graph is showing. Increased urbanization, movement, epidemics, wars, climate are all challenging us at a critical time where global health is so important. Look at what the threats that we have in front of us. Antimicrobial resistance is estimated that 39 million deaths may occur between 2025 and 2050, which will be costing about $3.4 trillion. Currently, we have about 1.2 million deaths occurring due to antimicrobial resistance. Look at what emerging infections did to us. In January of 2020, we were all watching news and wondering what this new infection is. It was in China. In January 20th, it shows a common connectivity. In February 15, 28 countries had been affected already. By March, 66 countries have been affected already, showing a common connectivity. And by March 20th, just 2 months, 165 countries had been affected by COVID, resulting to an estimated 20 million deaths. When you see these pictures, when we did global health and public health, global health security, we used to look at the pictures in 2019 and say, oh yeah, 2018, and say, oh, that pandemic, the Spanish flu happened then, it's the thing of the past, and if it shows up now, we will fight it now. But this is our time. This is just a few years ago. That's what we're dealing with. Non-communicable diseases, hypertension. I would just ask that you focus on the red part of this curve, which clearly shows the undiagnosed hypertension. Undiagnosed hypertension. And even those that are diagnosed, the rates of successfully treating hypertension is so low across the board. And hypertension results in about 10 million deaths a year. 10 million deaths a year. So it's still a big global health problem. Mental health, especially aggravated by COVID, is right there in our radar. There's nothing these days that you can deal with successfully without putting mental health right at the center. WHO estimates that about 240 million people suffered from depression in 2020. I'm sure that those numbers, this was just before COVID, I'm sure that number has increased significantly. Global health suffers from great fragmentation. I will just allow you to read the 5 fragmentations that I can document. One of them is many actors in the space. There are currently about 175 different initiatives in the world. Donor-driven, and I've been part of that, just as Ambassador Gooseby, driving the PEPFAR program, specific programs, create rigid boundaries, weak stewardship from countries themselves to really show ownership and leadership, the geopolitics of shifting, even the countries that underpin global health and governance and multilateralism are pulling out, and the lack of communication and coordination, and they all lead to significant challenges in global health. Let me just give you an example. I always said, if you take the calendar year from January to December and you're a mid-level career, you have a mid-level job in any organization, and you have to face travels across there, you just have no time to do the work, and this is all because of fragmentation. You start traveling in January, and in December you are still traveling, okay, right? Because you are invited in all kinds of manners of forum because of global health. So where do we go from here? We are at a crossroads. We may go somewhere, we may go nowhere, and we may go anywhere. So what defines where that vehicle will go? I think there are 4 things that will define that. One is the financial, the funding for global health, misinformation, lack of political leadership, and geopolitics. In my view, those are the things that we need to define as we chart the future for global health. Let's look at funding for 1 second. The US plays and has played a huge role in being a global health leader with a distant second, and we should be very proud of that. We should be very proud of that because, as I said, nobody can live alone. No nation can live alone, and if you think you can, you are sleeping in a revolution. In 2022, we contributed 32% of total international health assistance. And I even think it's more because of the Global Fund, 13%, we contribute 33% of the Global Fund. So if you add that to that 32%, it comes close to 40%. And a lot of that funding goes to Africa, 84% of that, and it has consequences. If PEPFAR was to stop today, what will happen? I think it's a fundamental question that we have to ask. Between now and 2030, about 4.4 to 10 million new infections will occur in HIV. So in other words, it would reverse the gains that we've made over the years almost completely, right? Death rates will range from about 700,000 to about 2 million, 2.9 million or 3 million. That's exactly around the time we were when we were all fighting, starting the HIV fight there. So again, it has implications. It's not about politics in Washington. I always say good politics plus good public health leads to good outcomes. But bad politics, you can reverse that and say poor politics completely handicaps global health, and that is an example of that. Look at the funding that, if you leave the US for 1 second, look at the funding reductions that we are seeing across in 2025 from the NGO and foundations, 22%, CEPI, the UN agencies, WHO, 17%. The only bright spots are the Gates Foundation and some regional development banks that we see some very small increases there. But overall, the picture doesn't look good at all. But the United States should remember that global health is not, as I've said, it's not about others. That we, as United States, have benefited a lot from global health investment in 4 areas. First of all, national security benefits, absolutely no doubt. The slide with COVID shows that we are not an island. Second, job creations. We have evidence that because of our engagement in global health, it had created jobs in the United States. Diplomacy, I just headed the Bureau of Global Health Security and Diplomacy. It's a strong weapon. It's probably our greatest soft power. It's our PEPFAR program and our economic growth and trades with other countries. So Global Health is not about charity for others. It is about us, about the 4 things that we should always remember. The American First strategy Global Health strategy is something we are looking carefully and watching. It has consequences on the 4 things that I just listed before. But there are elements that didn't need to be there. The abrupt disruption in programs just didn't need to be there, because before I left PEPFAR, together with Eric, I remember we had a meeting at the National Academy of Medicine to chart the future of how do we sustain the investment there? How do we sustain the PEPFAR programs there? And we were out there meeting with governments of the countries. On the left-hand side there is me with the Prime Minister of Cameroon, the US Ambassador, all asking these countries to bring their own commitments to the table. On the right-hand side is the Vice President of Nigeria with Peter Sands and Mohamed Pate, and they committed 200 million that will bring 200 million to it. So this was before the disruptions there. If you look at Botswana, I said last December I was in Botswana, met with President Masisi. He was still in office, and I said to him, President, you know, we've been doing this for almost 20 years. We need you to bring your own commitment. He said to me, we know what friends do for friends. You met us at a point of need, and without the United States coming to Botswana, the country would have been extinct. We hear you. Let's work together to 2030. So we had a choice of not crashing the plane, but landing the plane slowly so that others, our partners, can come on board. And it would have given us much diplomatic tools and leverage if we did that. In 2023, I went to the African Union, and I met with 33 heads of states, and I said to them, we have done this job for 22 years. Tell us your commitment. And they said, what do you want from us? He said, let's develop a journey to 2030, and secondly, let's call a special summit of the head of states where you recommit to finishing the fight against HIV/AIDS. So the point I'm making is that we didn't have to do what we just did. By disrupting programs, there was a roadmap on how we could do this in a responsible fashion. Countries will not forget the disruption that it happens. So, misinformation. Who could have imagined that the CDC, the US CDC, that we cherish a lot, will be attacked with bullets, with 500 bullets, because of misinformation? The person who did this is a Georgian man who blamed the COVID-19 vaccines for his mental health problems, and then decided to go shoot the CDC. For 30 years, I used to drive into the CDC with pride, with my badge, with my car label. Today, people drive into CDC with fear. Everybody has taken up the tag in their cars because they are afraid to be identified with CDC. How did we get there? And how do we get out of here? Misinformation. We should watch out for misinformation as we think of the future of global health. Lack of political leadership. We are here today in HIV, in the fight against HIV, and I'll add tuberculosis and malaria because of strong political leadership. When President Bush took the courageous step to create PEPFAR, it was the greatest act of humanity that I can think of, because we were desperate. Science had produced some results, but we just didn't know what to do with those results, like short-course zidovudine treatment or nevirapine to reduce mother-to-child transmission. It is only when President Bush did the State of the Union address and announced $15 billion that we changed the trajectory of HIV. That is good politics. Good politics means good public health outcomes. When I met the president in September of 2022, when I became the PEPFAR coordinator, I went down to meet him in his house, and I said, President, why did you launch PEPFAR? He said, I believe in God, and God has blessed this country, and to whom much is given, much is required. I'm so happy to see the impact of PEPFAR, end of quote. I offer you support. And I would like you to read the second part of this sentence, which says, this is about PEPFAR. It's a work of mercy beyond all current international efforts to help the people of Africa. Seldom has history offered a greater opportunity to do so much for so many. End of quote. That solidarity is what defines us. We cannot walk away from it and should not walk away from it. It defines who we are as Americans. The birth of the Global Fund. Just in September at the UN General Assembly, we invited President Obasanjo, the president of Nigeria at that time, and a Global Fund was launched with 200 million at the White House there. And fast forward today, the Global Fund runs around 60 billion and has saved about 80 million lives. That is the power of leadership, global health leadership, when these leaders all come together and decide that they have to do it. We just don't have that leadership today, and we need it today when we chart the future of global health. So there's this book I encourage you to read by Peter Piot, and it says, the AIDS between science and politics. But what it says in summary is that science does little good when it operates independently of politics and economics, and politics is worthless if it rejects scientific evidence and respect for human rights. So correct was at that time in 2015 when he published this book. When I look at that today and apply that today, it's like the book was written today. So geopolitics of that, look at WHO. WHO has literally been dismantled. How would WHO function with 40% reduction in its investment and is thinking of cutting its staff by 40%? That's what geopolitics does to global health, a strong global health pillar that we have had for 80 years. So where do we go from here as I conclude? I think, as I said, I'm asked myself the question, do we need a new global health order? The new order that balances national interests and genuine global collaboration to overcome fragmented efforts and inequities. Again, the subject of inequities. And there are a few elements that I've been putting my head together. I said, one, should we have a unified or a network of global health systems, or sometimes called Global Health Nexus, that brings together WHO, the Global Fund, Gavi, and other major players to share common governance structures so that we avoid mission creep? Should we have collaborative operational efficiencies between, say, Gavi and Global Fund, especially at the last mile delivery, where in the same countries, each program is doing the same thing, could be workforce, it could be service, supply chain management. Is it possible? Should we decentralize these organizations, right, for cost effectiveness? You have all these organizations are in Geneva. There's no reason why Gavi cannot be in Vietnam. The Global Fund cannot be in Latin America or Brazil or so. What the cost of just doing business in Geneva alone? I mean, can we decentralize? Can we decentralize? Now, because of the funding shortage, I see UNICEF decentralizing a lot to Kenya, but we should be doing that in global health. Each time we do this, we should embed equity, solidarity, keywords, solidarity, and transparent governance across different contexts, especially conflict regions there. We cannot neglect conflict regions in the world. And how can we leverage regional platforms to contribute to a new global health order? The president of Ghana recently launched the Ghana Reset, where it essentially says that we need to think of development not as usual, and that period is over. And what is required now is a fundamental re-engineering of a reset of the very logic of global cooperation, given what we have seen. And that builds on the Health Sovereignty Summit that he hosted in Accra on 4th of August. That summit essentially says that health governance must be democratic, just, and fit for the 21st century. Tedros was there, President Obasanjo and others were there. I think that concept is taking ground where we really sit down together and chart a new framework on how do we govern ourselves in global health, which is so important for our own humanity and existence. The power of regional institutions. We have seen, or we saw what Africa CDC did, and we've also seen what other regions are doing in the world. Should we strengthen those regional entities, and especially also focus on research and development in the region so that they can produce what we need in terms of vaccines, commodities that are common goods? That's the Africa CDC building, which I helped constructed from scratch between 2016 and 2022 when I left. When I left, the question my mind was, what do you do with such an important structure in Addis Ababa, which is part of the African Union? Shouldn't we integrate these structures into our global health security architecture and governance going forward? It's not just Africa CDC. If you look at the different regions of the world, whether you're dealing with the Gulf states have created their own CDC, the Asian countries have created their own public health agencies. The Europeans, of course, have the European CDC and the HERAD. That tells us something about the yearning of 8 billion people, 80 years since the founding of WHO, is saying we need to come together. We need to come together and ask a question. Is the architecture that we had 80 years ago fit for purpose today? People are yearning to have regional security instruments closer to their own populations. That's what that tells me about the different CDCs of the world coming together and saying we want to take the destiny of our own security closer to us. So to end, I think the training of our new generation, I've argued severally in this discourse that we cannot think of training public health experts as silos. We should also train public health leaders that will bring in a combination of skill sets, okay? Skill sets being leadership, management, public health, science, and diplomacy into the fold. Because people like this, Rudolf Virchow, who was a very renowned public health expert in Germany, combined all of those. He was a medical doctor, a health activist, a social reformer, a politician, and anthropologist. If I were to design courses for global health today, that is exactly what I would do, because I believe I've argued that you need a combination of all of that to create an impact. I was so fortunate to conclude that they asked me to be the ambassador for the prize that is named after him. So I'm here today to also publicize that prize and to honor that prize, that as we think through the next 25 years, we should ask ourselves the question, are we designing the curriculum for our training of our young public health experts such that we arm them with the tools that they can truly be effective going forward and addressing public health goals? Thank you so much, Chair.
Wonderful remarks. Thank you so much. Please join me again to thank Ambassador Nkongasong. His comments and remarks deserve deeper discussion, and we will join Ambassador Gooseby and Ambassador Nkongasong together with Dr. Monica Gandhi on a panel discussion, but we want to give you a break. So please take a 15-minute break and come back at just under 15 minutes, 10:45, and we'll dive into some dialogue. Thank you.